Hello, everyone, and welcome to the second session of Mental Health and the Second Wave, a NEESAMA webinar series supported by Samvad. Before we get into the panel discussion in the session, I'd like to remind you of our housekeeping rules. As you will notice, we have started on time, and we will be keeping to time through to the end of the session. So please make sure you're logged in. You will notice that you have been muted by host upon entry. This is just to maintain the session decorum. If you're invited to speak or you'd like to ask a question, you will be unmuted. We do have substantial time for questions in all our sessions. So you can start putting in your questions in the chat box as we proceed with the session. I will try and compile as many of them as possible for the panelists when we get into the question and answer segment. Lastly, it would be really great if you can have your videos on. It's nice to see faces in any such online discussion, but of course, that's the only not mandatory rule. So depending upon your network connectivity, please feel free to keep it on or off. Well, so this brings me now to my privileged responsibility of introducing you to the expert panelists joining us today. I'd like to introduce Dr. Murraydharan, who is Professor of Psychiatry and the current Medical Superintendent at the National Institute of Mental Health and Neurosciences, that is NIMHANS, in Bangalore, India. I welcome you to the session, sir. Very happy to have you with us today. Dr. Arun Kuvar is Consultant Child and Adolescent Psychiatrist at the Kanti Children's Hospital in Kathmandu, Nepal. To those of you who do not know Dr. Arun, he is actually the person instrumental in setting up the entire child and adolescent mental health initiative in his country. So we're very honored to have you on the session today, and we hope to learn a lot from you. Ms. Anne Moore is the Group Nurse Director for Safer Care and Director of Infection Prevention and Control at Northumberland Tyne and Wear NHS Foundation Trust in the northeast of England. She leads the Trust COVID-19 Emergency Gold Command Response. I've had a very brief interaction with Ms. Anne Moore before we're meeting today online. It's just been so enriching to learn the span of your expertise and the span of your experience over the last 4 decades. So it's a real pleasure to have you with us on the session today, and we hope to again learn a lot from you going forwards. And let me also point out that it is particularly a pleasure to be interacting with this panel because, as you will notice, we have expertise today on child and adolescent mental health, adult mental health, nursing in mental health and other areas, as well as administration. So all 3 panelists actually have a rich administrative experience, and which is what the panel discussion today, the theme of the discussion today is really about. It's about looking at mental health systems and how they need to be responding to the pandemic. So we're really lucky to have you all with us today. Well, before I get into asking the panelists to share their thoughts, I'd just like to briefly present the theme of today's session. I'm sure you'll all agree that as different parts of the world, as different parts of South Asia continue their fight and their struggle against the COVID-19 pandemic, there is an ever-brimming parallel theme, which is the need to get back to normal life on both personal and professional fronts. It's been called COVID fatigue, and increasingly we realize that COVID fatigue is a very, very real and personal phenomena. The pandemic has taken a toll on physical and emotional health by severely depriving us of our usual coping methods. You can no longer go for social get-togethers. You can't visit the park with your kids. You can't eat out. So, but then again, probably a phenomena like COVID fatigue is just the very surface of what the mental health impact of this pandemic has really been. In fact, some people are talking about the mental health impact as the 4th wave. So, there is the first wave of morbidity, mortality, which peaks very quickly with, COVID-19 coming in and then starts to settle down. The, chronic conditions, the disregard for non-urgent, non-COVID conditions. So all of that, seems to peak in the initial part and then it comes down ultimately. But the mental health impact, the psychic trauma, mental illnesses, new onset mental illnesses, economic injuries, burnout, all of this just doesn't seem to be leaving us, even though the COVID-19 illnesses may have actually started to diminish. And given that, especially in the case of children, when you have school dropouts, a lot of abandoned orphan children, parenting stress, caregiving stress. So all of this just makes the problem that much more serious and intense. And this particular survey from Canada has pointed out that it is actually the youngest of the lot that seem to have the highest proportion of clinically significant anxiety. So it's not just when you suffer from COVID that there is a mental health impact. The mental health impact is already occurring like a silent pandemic in the younger generation, even though they are less directly infected and less likely to manifest the COVID-19 illness per se. So then, of course, there have been guidelines. These two are from the WHO that talk about integrating mental health, that talk about primacy of preventive approaches, early identification. But then the reality has been that, and I don't know how many of you have had similar experiences as all of us here in India, but for the better part of the pandemic, mental health services have actually, they have not been as well utilized as they were being so earlier. Now, of course, mental health has always been an issue. We have never probably reached an optimum as far as mental health is concerned, but whatever was existing, even that kind of went back because priorities shifted. People were not coming in, there were travel restrictions. So, you're all familiar with whatever's there on these slides, but just to kind of put the theme in perspective. And of course, this impacted a lot of community-based, school-based, so everything that was outside of the clinic got impacted much more than did clinical services. Because if somebody's severely mentally ill, if they're in urgent need of mental health care, they would still come. But it is the minor morbidities, it is the community-based work that took a real big shot with the coming in of the pandemic. And then, there has been response. It's not that mental health has not responded to the pandemic. So we have responded to the pandemic. This is from the WHO survey of 130 countries, where if you'll appreciate, the largest proportion of countries have responded by, shifting a huge deal to telemedicine, to teletherapy, helplines, including infection prevention and control into their mental health and other healthcare systems. So, the digitization and infection awareness, infection prevention awareness, these are, probably the two biggest response patterns that seem to have emerged as we have learned more and more in this pandemic. However, very few countries have looked at alternative modes of service delivery. Very few countries have looked at task shifting. Very few countries have, looked at individual training. So how do I need to upgrade my skills to now work in this pandemic or post-pandemic era? So those are the questions that don't really seem to have been well answered. And as I'm sure all of you have experienced this at some point, where it's not just those who are infected, but it is also the healthcare professionals who, given the kind of intense decision making they go through every day, given the multiple, problems at the workplace, even something like shortage of personal protective equipment, so something as small as that to the much larger psychosocial impact. So all of that does take a personal toll on the individual as well, ultimately leading to a lot of burnout, moral injury, and even mental morbidity. So with that, what we are looking at today is that we're looking at the entire mental health system. We're not, so each and every single one of you, whether you're a psychiatrist or you're a psychologist or you're a nurse or you're a social worker or you are a teacher or you're a childcare institution worker, it doesn't matter what arm or what kind of a mental health system background you come from. We're going to try and direct this session to the entire system and to see the kind of answers that we can generate. So the question that we're asking is, are mental health systems equipped to handle the pandemic. And in just a moment, I will ask the panelists to respond to this theme. But I thought it really fitting to introduce a question that already came in by email from Dr. Jayakrishnan Menon, who is a psychiatrist practicing in Kerala, um, who feels that given that mental health system has always been in shortage, it's always been ill-equipped, probably the better questions are how can mental health systems be better equipped to triage and identify people with severe mental illness? So he's probably trying to look at it as a selective area that we need to understand better and direct our energies to address better, because that is most likely to become more problematic than the minor mental morbidity. And how can mental health systems respond to the fallout of the pandemic on individuals, those who are already under their care? So somebody already with a mental illness, how do we help them first? So can we, be really focused in our approach here? So I thought it's, important to put that out before I get the panelist response. So with that, may I now invite Dr. Arun Kumar to give his response and thoughts on the theme. Dr. Arun Kumar, over to you, sir. So you need to unmute yourself.
Okay, namaste. I'm Dr. Arun Kumar. I'm a child and adolescent psychiatrist. I'm at Kathmandu here. When we talk about the systems and what resources we have, and we just talked about what we don't have and what we do with what we don't have. It's a classic question. So one good thing is you can see my background. So this is the first child and adolescent mental health unit that has opened in Nepal. So we are running outpatient facility right now. And if we haven't had COVID, we would have started inpatient by now. But anyway, so we do have now at least one functioning child and adolescent psychiatry unit in Nepal. So when COVID happened, and suddenly there was lockdowns, and when nobody was coming to the clinic, we quickly realized that we had to do something. So we already have a hotline number that we had used. We extensively took it out, and we started doing tele visits. So we're already doing few tele visits. Before we were doing more telephone visits, but we converted to tele live video evaluations. One of the other things that quickly came up was when the Zoom classes started. Teachers started calling. We have a network of schools that we work with, and we started getting calls from the school principal that teachers are so anxious about doing at Zoom classes. Could we help them? So we started working with teachers. We suddenly realized it's not teachers; it's also the student who need help. So within a week of we started doing these sessions to the teachers and students. We got so overwhelmed with the response and need for it. So then we developed two manuals. One is on how to deal with the COVID-related stress directly to the children, and one is to the teachers, parents, and caregiver on how to manage COVID-related stress. So we developed two manuals with the help of UNICEF. We got some funding, and we end up training 90 community counselors. And the 90 community counselors, what we did was we also empowered the counselor. So part of the funding, what we did was, we not only train them, we'll also pay them to do these sessions. So it really went like a, cascading model where within 3 to 4 months, we conducted more than 2,000 sessions. And we had reached more than 20,000 children and 20,000 parents and caregivers. So, when that whole thing started, it got me thinking that, there are a lot of things that we don't have. It's about what we have and how we can effectively use resources that we have. So, it is definitely true that, rural part of Nepal still has problem access to internet, Zoom and stuff like that. But significant part of the Nepal has internet, at least through mobile phones, and a lot of schools are already using mobile platform for teaching. So we just utilize that platform, and so the UNICEF, when they looked at our number, they were so impressed that so we have more funding to do 20 more thousand children and 20 more thousand teacher student caregivers. So it was a good opportunity in a way that child mental health is something that people don't talk about. And I'm not sure, we have done a lot of these sessions, and I'm sure we might have done something. But the most important thing, what came out of the whole thing was, at least now people know about child mental health issues. People know that the children can have stress. And part of the training, what we also do is care over to pathway, like, pathway to care. So it's a very simple, PFA, psychological first aid, come basic, basic stress management to the children. We have a little session on a stress management. We teach them relaxation, and we teach them on how to identify severe symptoms and when is the time that they should ask for help, and for the parents and teachers and caregivers, that when they need to refer and where to refer. So I think it is work very well, and we have 10, almost like 5 psychiatrists and 5 psychologists in our team. We are getting really a lot of calls in the community. So I think working with we are also trying to work with government in trying to. We have already developed a MS gap package that is specifically for children, and we are in process of implementing through the government and going to each district throughout the country. So it is definitely challenging. Funding is a major issue, but I think if we just think a little bit entrepreneurship or innovation way, that let's utilize what resources we have and how we can use them effectively. So if we can do that, we can change the system. Have I done enough time, or do I have more time? Or
Yes, this is great. So what you're telling us about is that you have, as a first response to the pandemic outbreak, you have taken a more awareness building approach, where you have reached out to as many people as possible in the community, teachers, parents, community counselors also you mentioned. So you have taken a more awareness and psychological first aid approach to responding to the pandemic from your hospital. Thank you for sharing that, sir. I'm going to come back to you about the community counselors and how that worked out. But now let me get to Ms. Anne Moore. If you could respond to the theme and share your thoughts.
Sorry, did you want me to respond to the just to the point there? Sorry, you didn't want me to put my presentation up yet, no?
No. This is the point where you can come on with your presentation.
That fantastic summary. Thank you very much for that. Absolutely. Having had experience of visiting some of the areas within India over the last 2 or 3 years, I do understand some of the disparity and some of the variation in services, but I was very struck when I was there about how the community counsellor roles were starting to be developed. And certainly from what you've just described, I can certainly see huge benefits that we could benefit from, because I think even our own community services perhaps haven't had the reach directly into homes in exactly the same way, because of some of the COVID restrictions and some of the infection control guidance that we've been working with has perhaps created an increased anxiety around the ability to actually engage at that level. So I'm very heartened to hear of your experiences, and certainly feel that there's some lessons we can all learn there. Thank you.
Ms. Anne Moore, you can also present what the UK's response, or what your hospital's response has been to the pandemic.
Okay, thank you.
Yeah.
So I'm just going to put that up. Can you see that there?
Not yet.
I do apologise for that. I know you've got it, Isha, at your end. I don't know if it's easier to put it up from there. Just because
I can do that.
Can you do that?
Yeah.
Thank you very much. Apologies. We use MS Teams in our organisation, and so Zoom is not something that we're as familiar with. So I do apologise for the disruption to that. But just first of all, just thank you very much for inviting our organisation, Cymru Northumberland Tanaway Foundation Trust, to participate, and myself in particular. Just really wanted to remind people that we are a very large organisation within the north of England, which we cover adult, children, older people services across a whole range of mental health, learning disability and autism. And we have a range of inpatient and community settings across a very wide and diverse geography of both rural and urban populations. Our staff are around 8,500 to 9,000 staff, depending upon some of the work that we're doing. And so for us, as part of the pandemic, we've needed to work in a very different way, dependent upon the community prevalence that's occurred within the areas that we've been working. We were very fortunate that we didn't have any significant outbreaks in terms of our inpatient or staff areas until around September, although there were very high levels of prevalence of COVID across the whole of the north of England. So from March until September, the various lockdown and restrictions appeared to be having an effect. But then when that was released over the summer, we did see a significant difference. Next slide, please. I think our initial response was very much a major incident and surge response, which you're all very familiar with from your own experiences. And I think what worked well was that change to a command and control model to make decisions quickly. And nationally, the UK government enabled us and supported us with the support of the Department of Health to make decisions locally and focus on what was important for our services. But what wasn't so good was the focus nationally was still very much on physical healthcare and physical as in acute organisations, not mental health providers. And so basic things like PPE had not been allocated to us as an organisation. The closing of services in the acute sector to release beds meant that there was an impact on our diagnostics, particularly around memory protection, dementia services, because we didn't have access to some of those services as easily as we would have normally. And that created significant anxiety for families and patients and for staff who were trying to move patients through a pathway. Because our GP, general practice, also began to stop having face-to-face contacts, there was an increase in anxiety of the general population, but also some of our patients who either had a pre-existing condition. You could see that there was some deterioration, and we started to see referrals coming in that were increasing into both adults and into children's services. However, what was interesting was that with children in particular, well, because schools had moved to homeschooling, we actually saw a reduction from schools who were perhaps the ones who were spending a lot more time with children and able to do those assessments on a day-to-day basis. So again, we felt that that was a hidden concern. We also started to note that there were increases in safeguarding, domestic violence, and also hidden harm. Some of that was our patients, some of that was actually our staff who were working from home and weren't having that interaction within the workplace, where we had some of our corporate and administrative staff, as well as some of our community staff who were able to work from home with the new models of working. And I think overall it reinforced that we still had inequalities around accessing a whole range of issues. There is a big disconnect sometimes between infection prevention control measures and myself as the director responsible for that, but also trying to adhere to the Mental Health Act in terms of patient liberties and maintaining patient rights. Sometimes some of the IPC measures were seen as restrictive, even though we were trying to work within them. And I think the important thing has been that the restoration and recovery, because of the waves, the peaks and the troughs, where we've seen a reduction in COVID, but then we've seen a peak and a rise, has meant that our waiting times have increased, and we have seen increased admissions, and patients have actually presented with their mental health and learning disability presentations a lot more profound. The next slide, please. I think overall the impact has been on social communication across the whole of our patient population. I think the technologies have been greatly appreciated. We didn't have Microsoft Teams. We always had to come into a room to meet. We didn't even have Skype in the same way. We had it for a few of our services, particularly forensic services, with inreach into prison and custodial settings. So yes, it has made a difference, and it did mean that we had an opportunity where we didn't have the opportunity to use clinics. We could then still do have our interactions with patients as well as with staff as well. But I think what it highlighted was, again, access is quite disparate. There is digital poverty. I think there's an assumption that everybody's got a smartphone or everybody wants to engage with telephony, but that's not necessarily the case. I think a lot of the national guidance and supporting literature, even if you weren't using technological approaches, didn't actually meet the needs of patients who needed easy read or literature that was actually describing what COVID was and how to access testing and how to interpret some of the restrictions. And I think the imposition of face masks in so much of our environment, for us certainly, has created massive barriers around communication, and in some cases in inpatient settings resulted in violence and aggression in a number of areas, as well as that feeling of that interaction around therapeutic touch and the feeling of isolation from a lot of our patients as well. Next slide. I don't think I need to go through every point here from the infection prevention control measures, but I do feel that we were very positive in that everybody embraced this and felt that it was everybody's business. And we have worked with the National Department of Health to reflect going forward that the guidance needs to be written for mental health organisations and not just for acute settings. I think we've certainly tested out what it's like for patients to isolate, and the fact that we introduced testing for PCR testing to enable our patients to move around was so much of a benefit. But again, it was something new that we hadn't experienced before. I think so what we have seen is, though, some of the behaviours of some of our staff and taking patients out into the community has meant that if staff don't comply, then clearly that does mean that there is a greater risk of transmission within the workplace. And that's been a really difficult message to get across to some of our teams. Next slide. There's a lot of developments that I've listed here in terms of how we really did respond in new and innovative ways. I think just to highlight a couple, the development of our virtual mental health emergency departments, working with crisis and psychiatric liaison teams into the acute hospital admission EDs, really did help to get our patients quickly assessed and fast-tracked and moved into the correct pathways. And we will keep that going forward because that has made a big difference. The enhanced physical health response so that we could keep our patients in our services longer. I know within your settings, from certainly my experience of working with a lot of doctors and nurses who have been involved in the last 2 years, you have a big focus on physical health care. I think that's admirable. It's not always the same within our settings, where the focus is more on sometimes the psychological and emotional health and well-being. So that integrated approach has meant that we've had much more of an opportunity to deal with some of our deteriorating patients who did get COVID in our services, and therefore reduce the burden on acute services. And I think the other element was that we had nursing and medical students who we actually brought into the workplace to work alongside colleagues as part of the workforce. And that meant that we were able to really give them that first-hand experience during their training in a way that perhaps other students were being pulled away from the learning environment. So again, that was a huge advantage. And then my last slide, if you'd be so kind, just put that one, the last slide up, please. The emotional health and well-being. The exhaustion has been apparent as the pace around the positive cases reduced and people had more time to reflect. The adrenaline was dropping, and that was right across the administration and the frontline clinical services, and as much within mental health and learning disabilities, where struggling to keep patients engaged when they couldn't go out and do the normal activities or couldn't have sort of PPE restrictions removed, I think has been exhausting for everyone. We've put a lot of psychological support into both our staff who weren't able to be at work because of shielding. We have seen an impact in general anxiety. The impact of wearing PPE has also had ramifications. But we have also, as an organisation, been called on by partners to offer support to acute hospitals and to the care home sector, the independent sector, because of the trauma that they were experiencing with the high proportion of mortality that they were witnessing and some of the really difficult challenges around treatment. And we've also given support to staff families who have lived outside of the UK, who have been in challenging positions, such as yourselves. A lot of our staff have had families who have been living in other parts of the world that have been impacted by COVID, and we've really supported their health and well-being and their families' health and well-being with a range of measures. And overall, what we've tried to do is learn to balance a command and control approach with a compassionate leadership style, which is often quite difficult to manage when you have to put so many restrictions in place. So thank you. I hope that was a helpful summary.
Thank you very much. That was indeed quite descriptive in terms of the many levels of responses that have actually come in. I'd just like to reiterate a couple of things that you spoke about. So one of the things that you said is that, and this is something that Dr. Arun touched upon as well, that the pathways to care, so you said that the school-based referrals, other screening measures in the community, which have now become defunct because of social distancing and the lockdown. So other channels of referrals have actually, taken a back seat. So you're much less likely to meet a lot of children and adults who may be mentally unwell. The other thing that I also want to talk about, something that you said, is the restrictive nature of the infection prevention and control. So whereas you can go all digital, but digital is not how you can access anyone. But then doing this in the clinic, the loss of the therapeutic touch, the distancing that comes in. So all of that actually takes away part of the healing that is meant to be there. So thank you so much for that. And we're going to come back to some of this through the Q&A. May I now ask Dr. Murraydharan to respond to the theme?
Good afternoon, everyone, and thanks, Isha, for a wonderful introduction. And it was a pleasure listening to the other two panelists. So they've set the bar fairly high, and I need to try and reach that now. So I just have a few slides to share. Right. Okay, are my slides visible? All right, thank you. So this is the theme for today's discussion, and I must say it's a very, very useful and a very appropriate theme and requires a lot of discussion. So let me just start with this ominous statement that I read somewhere, that history teaches us that there will always be more psychological casualties than physical casualties as a result of disasters, and that includes pandemics. So that is something that we must keep in mind as we deal with the second wave and probably the third wave, and the waves will come and go, but the psychological sequelae are going to be there. Now, this is the treatment gap that was already in place in India before the pandemic started. And you can see that, for most of the severe mental disorders, the treatment gap was more than 70%. Highest is for substance use and, depression. It's also, disheartening to say that this is not a statistic that we're proud of. India accounted for 26% of the world's suicide deaths. These are the people who did not have access to care even before the pandemic started. And this was the kind of resources that were available for our patient population. And again, before the pandemic started. And in terms of the availability of surplus of deficit psychiatrists in different parts of the country, as you can see, there is a deficit of psychiatrists and mental health professionals across the country. And the district mental health program, which was initiated to actually overcome this deficit of mental health professionals, has not actually been able to percolate to all parts of the country. So that was the background. And then you had the first wave, and then you had the second wave. I don't know whether to call it the second wave or the first tsunami, because that's the kind of increase in numbers that we see. And what happened? So there were 2 lockdowns that India experienced, and the impact of these lockdowns are that most of the government general hospitals were designated as COVID hospitals, which means that the mental health care in these hospitals was shut down. Outpatient services were closed across the major hospitals in the country. Only emergency services and IP care was there. Even what was available to access that, public did not have transportation. It is still an issue in Karnataka, where NEMANS is located, where inter-district travel is still not permitted. And accessing healthcare became an issue, both physically as well as through telemedicine, and of course the earning. A lot of our patients come from the very poor socioeconomic strata. So without regular earning, with loss of jobs, with whatever the difficulties the pandemic has brought, it's difficult for them to allocate resources that they have for mental health care. Further, I think there's an interesting situation where the psychiatrists got confined to the mental hospitals rather than patients. And so we had to find a way to reach out to patients, which is what most people have been talking about. And this is a study that I'd like to draw your attention to, which talks about the mental health implications of COVID-19 and its response in India. So the common problems that have been highlighted include stress, anxiety, depression, anger, fear, and suicidality, like I said. So these are adding to the problem that was already there. And if you can take a look at the population that required mental health care, suddenly you find that there's a whole new group of people: migrant workers, COVID-19 patients, their contacts, their survivors, their family members, frontline workers, general population, people with pre-existing mental illness. As you can see, they form only a small proportion of the population that required mental health care. And of course, we all talked about the pediatric population and the geriatric population. So if you can see, barring this box here, the rest of the boxes are talking about a new group of people who required mental health assistance. So the denominator of people requiring mental health care has gone up tremendously because of this pandemic. And this is what this article also says, that stress, anxiety, depression are there in about 16 to 28% of the population across the world, which is far more than what was seen prior to the pandemic. And of course, fear of pandemic is one such significant mental health issue that has been observed. So what pandemic are we talking about? There has been a lot written about so-called hidden pandemic of mental health that is actually going on. So maybe like Isha pointed out in the initial slide, a 4th wave would be a mental health wave, but actually there's a lot being written about that. There's a hidden pandemic of mental health that is actually going on. And what are we doing about this hidden pandemic? As I've just highlighted the dates on these articles just to say that these have been written for almost a year now. And as you can see, there's another, more recent articles have also spoken about is, the mental health pandemic that people are experiencing. And the most recent one from India, which talks about has it exacerbated India's hidden mental health pandemic. So the mental health pandemic was always there. It has just gotten worse, and we have not yet gotten around to addressing this hidden mental health pandemic that is going on. And lest we forget, we have to do this on the background of a shrinking economy, the lockdown-related loss in economy and revenue, the cost of COVID management. Now, let's not forget that it's quite costly managing COVID, especially those requiring ICU care. So the government is going to divert all the available money towards management of COVID. So what happens to the funding for mental health? But that's a very, very important question. So whatever new things that we want to do or want to plan, let us not forget that we're going to do it at whatever limited funds are available for mental health care, because COVID is going to consume a lot of human resources. It's going to consume a lot of money. So the question for today, are mental health systems ready to handle the mental health pandemic, which I say is currently hidden, and what needs to be done? I'm going to leave you with a couple of slides now for discussion. Now, we already agreed upon the new set of people who require interventions for mental health related problems. So what is it that we need to do? What is it that non-governmental organizations need to do? What is it that the healthcare professionals and private sectors need to do? What is it that an institution like NIMHANS, which is a tertiary care center, has to do? Of course, a lot of things have been done. A lot of things, I'll be repeating what others have said. So we've done telemedicine-based services, we've done telephonic, calls to patients. We've tried to reach out to them. We've made medicines available in the peripheral health centers so that the patients can access it from nearby. Some psychological interventions were provided. The problems of migrant workers were addressed. So many of these things have been done. That was done during the lockdown. That was done during the first wave. Now, once the lockdown is lifted, we are going to suddenly see a lot more people wanting to access mental health care. So are we equipped to handle them? So these are the things that I would like to draw the attention of the participants and the panelists to. What needs to be done in terms of the emergency care? What needs to be done with respect to acute inpatient care? Now we have this unique problem where suddenly you have a group of people who are COVID positive with mental illness, and you have a group of people who are COVID negative with mental illness. So what kind of acute inpatient care can be provided to these people? Outpatient services, this is what accounts for the majority of the mental health care that is provided by us. What happens to acute outpatient care, and what about follow-up services? So these are the things that I think we need to discuss about. And in terms of therapies, biological therapies, psychological interventions, I'm sure a lot of people are receiving ECT. I'm sure a lot of people wanted to get TMS or TDCS or, numerous other interventions that are available only in the hospital, which they would have accessed otherwise. So how do we ensure that they get this in? A patient with suicidal risk needs ECT, right? So what are we going to do about it? So these are some of the questions that I think we need to discuss. And I think I'll leave you with those slides so that we can continue with the rest of the discussion.
Thank you very much, sir. If I can straight away direct a question to you. So something that Dr. Jayakrishnan Menon had asked that I presented as well. So because you referred to the treatment gap, and you said that the treatment gap was anyway humongous pre-pandemic. And what Dr. Menon is suggesting is also that, should we actually be prioritizing severe mental illness, severe mental morbidity as, our goal in terms of really treating the mental health ramifications of the pandemic? So what would your response to that be?
It's much like, the moral dilemma that an anesthetist faces, right? If I have 2 ICU beds and I have 5 patients who need to be admitted, whom do I give the beds to? So that's the kind of question that Jayakrishnan has asked. When you have only, say, 3,000 psychiatrists in the country who needed to look at a population of 10 crore with mental illness, and suddenly you find that 20 crore people require mental health care assistance. So whose needs am I going to address? Am I going to address the needs of the people who are already severely ill to ensure that they stay well? Or am I going to address the needs of the people who have become newly ill, who form a great proportion of the productive population of the country, whose mental health needs have to be addressed so that they can go back to being productive and improving the economy that will support the rest of the mentally ill population? So this is a difficult question to answer. But having said that, I think what it comes down to is each center putting their priorities right and saying that, okay, this is what I'm trained to do. This is what I have the resources for. This is what I have the ability to do. So let us focus on doing like for example, NIMHANS has to focus more on patients with severe mental illnesses. And we will have to make sure that the people who are severely mentally ill get the care that is needed. We have to make sure that, the people who require acute and emergency care are provided that. We should also use our resources to enhance capacity building so that other people can be able to provide what would be psychological first aid or basic psychological interventions closer to, so you don't need everybody coming to a tertiary care center. So we should strengthen our primary care systems. We should strengthen whatever secondary systems are there. The medical college-based hospitals need to be strengthened to provide psychological interventions. I'm sure a lot of them just require, brief inputs vis-a-vis patients with severe mental illnesses who would require. And again, this is also a time where we are likely to start blaming the government and blaming the systems that are already in place that it has been neglected. Yes, that's a fact, it has been neglected. And complaining about it is not going to change things overnight. And like I said, the cost of COVID treatment is enormous. Each one runs up humongous bills. And in this context, to expect more resource allocation for mental health is not going to be easy. Of course, the government is waking up to the mental health crisis that is there. The fact that the service providers themselves are becoming, ill because of mental health issues. So I think there will be a lot more attention that is being paid, but I think it will come down to each center being able to recognize what strengths they have, what they can offer, and to try and ensure that they do it as optimally as possible.
Right, sir. Thank you for that. I think that's a useful message for all of us to take, that we need to recognize where each one of us and where our institution is positioned in the mental health system, and then decide what is the best capacity, best skill that we have, which can then be translated into help for those with mental health care needs. This kind of pushes us. So you spoke about NIMHANS and it being a center of excellence and something that should actually take up the leadership role in training others. A parallel to what Dr. Arun spoke about, so their center has been training community counselors. And so let me now get to that. But before I ask you to respond, I'd also like to take in Dr. Arnab Bhattacharya's question here. And he says, can we train lay people with basic mental health capabilities, as Delhi is doing, for tackling physical COVID problems by general healthcare workers in anticipation of the third wave? Okay, so I think Dr. Bhattacharya is kind of trying to link a community worker in terms of handling both the medical care needs as well as the psychological care needs. So if you can also respond to this when you talk about what the program for community counselor training was like for you.
The question is for me, Arun, Dr.
No, sir,
Arun.
the question is for Dr. Arun.
Thanks.
Okay.
Yes, sir, we can hear you now.
Now, okay. So there are two components. One is, what kind of services you are trying to deliver, right? So our approach is providing basic psychosocial support, training them on identifying, rather than a syndromic diagnosis. We focus on trying to figure out what are the general symptomatology, that can be, red flags. Let's say somebody is having a suicidal thoughts, that's a red flag, right? So somebody is not sleeping, that's a red flag. Somebody, we had a referral where a child was washing his hand all the time. So, so we talked more about general symptomatology and what is a threshold for referral. And you can do the same thing to the healthcare workers too. So in fact, we have worked with Ministry of Health in Nepal, and now we have developed a training manual for nurses who are working in COVID wards and isolation centers on how to provide basic psychosocial support to their patients. So, some of these, some of the components of basic psychosocial supports are, these are not rocket science. These are basic stuff that you can teach to most of the, let's say at least somebody who is more than high school educated, and if they're more psychologically minded. If not, sometime, we have a group where normally we run like 4 hours or 2 hours of training session over the Zoom. And if we are in doubt, what we do is when they conduct a first session, we sit down with them in a Zoom, and then we provide a feedback. So I think that is definitely doable, and we are already doing that in Nepal. And one more thing to understand about the community counselor is a lot of people really want to help, and a lot of people are home. if you can tap that population who are young, energetic, and who wants to help, and who are not doing anything at this time. So that because to achieve a 2,000 training in span of 3 months, we were going crazy that it was so hard to even track the number of sessions. But I think once you empower these people, the whole idea was we could have done training ourselves, but we could have never ever managed to reach so many people. So I think it's empowering them, and also a part of the training is figuring out what is their threshold and what is the point that they should support and what is the point they should refer. So if we keep that to minimal, simple, I think it's definitely doable. Thank you.
Thank you, sir. So again, so it's about you've kind of taken the two things together. So you integrate mental health care into general medical care, and you find out all arms of the general medical care system that can actually be tapped in. So you train nurses, you train other people working with patients in wards who you can actually impart some basic psychosocial support skills to, and that can already start happening. So you don't have to actually wait for this patient to fall ill and come to a mental health system. It can already start happening at the periphery. I think an also interesting point about asking for volunteers, because like you rightly pointed out, a lot of young people are actually quite keen on assisting. They do it for other general medical needs, for oxygen supply chains. There are constant WhatsApp messages on how things can be channeled. So that's again a good resource that all of us need to take home with us and see how we can implement it. Let me now come to Ms. Ann Moore with a question from Selmi Jose. So she's asking about, and I'm trying to see if this is something that you have faced in the UK, and what is it that you generally, is there existing protocols on how you manage such a situation, and if we can learn from that. So what Selmi is asking about is, when a person who is already under treatment for mental health, for a mental illness, so when this person gets affected by COVID-19, because of their immunity getting affected for a period of time, because of they requiring a lot of medical attention, the psychiatric treatment is often paused, or there may be a dosage reduction, and this becomes a threat for improvement of their mental health, and perhaps will also contribute to the physical health outcome ultimately. So while handling such cases, what do we have to, what should we keep in mind? How should we approach this situation?
Thank you. Yes, we have exactly had those examples where we've either been caring for the patients within our own settings with an enhanced physical health care plan to manage their COVID symptoms. And absolutely the balance between treating their presenting mental health condition and the COVID condition can often be in conflict depending upon the severity of their condition. But also the deterioration of both is obviously something that I think our practitioners, our nurses, doctors, multi-professional teams have had to really get to grips with. I think we manage it very well when the patients remain within our own environment, if they are inpatient with us. The bigger challenge was when they needed to be transferred to the acute hospitals for the more enhanced oxygen therapy, or even escalating into high dependency care. What we would normally do in those circumstances is we would have a dedicated staff group. I don't want you to think we've got lots of staff who, and it's an easy decision to make. But because of the needs of the patients and the best interests of the patients and the expertise that our staff have who know that patient, then and actually care for the mental health needs of the patient alongside the physical health care team. And our consultant psychiatrists or consultant psychologists would be working again very closely together across that pathway to make sure that the best interests of the patients were being served. I don't know that we would get it right in every situation. I think the area that we've possibly got the greatest concern would be patients who are in care homes, which I know is quite a different setup, where actually they're being dealt with in a very different way, but there's a lot of patients who may have dementia or other cognitive difficulties, and sometimes what we found was by the time those patients were admitted into the acute organizations, their mental health had deteriorated so significantly. So what we've done is we've been working very closely with the independent healthcare sector and our local authorities to make sure that we're available for advice and support, which we call scaffolding, to help to ensure that any particular concerns that that may be emerging in another sector won't deteriorate to an extent that the staff don't feel able to deal with it.
Thank you. So I hope that Selmi, that gives you a better idea. So it's about if you can prioritize an inpatient treatment along with a good CLP arrangement, so where there is constant consultation liaison between the medical specialist as well as the psychiatrist, because everything will have to be individualized for such a patient when that comes in. Now, because this is really important that we touch upon it, everyone's been fascinated and totally consumed by telemental health. So I'm going to first ask Dr. Murraydharan to share his thoughts on how that, how he thinks that's going to play out in the immediate and the long term. So, what do you expect out of telemental health? Is it really going to answer all our woes? Is it going to answer the situation?
Thanks, Isha. Yeah, I think that's something that we need to look at from 2 or 3 different perspectives. One, telemedicine has always been available. It's just that we never used it, right? And now the pandemic has necessitated that we make use of it, and so we're doing it, right? Now, it's important for us to continue doing telemedicine even when the pandemic eases. I think that is going to be a significant step. And I can assure you that did not happen. Between the first and the second wave, we went back to being busy. All of us got back to seeing patients the way we were prior to the pandemic. And telemedicine went into the cold storage. And now the second wave hit, the lockdown happened, and all of us are back with telemedicine. So telemedicine, while it's always been used as a platform for training, as a platform for providing clinical care, it has been much neglected. But I think the government has also woken up to this, and they have come up with this platform for all patients called eSanjeevani in India, which I think people may be aware, many of you in the audience may be aware of. So the government has initiated e-platform based, home-based stay-at-home OPD, that's what they call it, stay-home OPD services. So some of these telemedicine-based services will keep coming up. The problem with such services is that continuity of care is going to be an issue. So when there is a government-run service like that, you may talk to one doctor today, the next doctor may not have access to your records, or they may not have access to your information. So how do you ensure continuity of care? 2. The third thing is that now, because of the lockdown, people are comfortable using telemedicine for follow-up care. What about patients who need a first consultation or who need to be seen for the first time? How many psychiatrists or neurologists would be able to or would be comfortable providing telemedicine-based consultation for a new patient without actually being able to examine them? Now, this brings all these questions into play. And the most important question that I think we should raise is, how do you ensure quality assurance in a telemedicine-based intervention program, right? Now, that's the thing. We all have various kinds of accreditation. We all work with different systems which ensure that quality of care that is provided is good. But with telemedicine, there's absolutely no control. There's absolutely no. And what about other patient issues like confidentiality, which can go for a toss with telemedicine? So these are some of the issues. So telemedicine is here to stay. There's no doubt about it. Telemedicine guidelines are being framed by different countries, and it's imperative that all of us stay as close to the guidelines as possible, both in the interest of patient care as well as the safety of the treating mental health professionals. It's also important for us to look beyond the pandemic and see how telemedicine can become applicable and coexist side by side with the in-person mental health care And it is very, very important for us to build in quality assurance. There has to be some audit of these telemedicine-based services that we're providing. Otherwise, it will be like, okay, it's like we're doing a favor to a person who has access to internet. We have to assure that they get the same quality of care that they would get with an in-person consultation. Thanks, Isha.
Thank you, sir. So obviously a lot of issues to resolve going forward with the telemental health. And let me transfer this discussion to Ms. Anne Moore, who was sharing with me how your experience with setting up the telemental health framework for patients. Then you finally started realizing that perhaps we need to figure out better ways to go back to face-to-face.
Yes, definitely. What we found was that there was a huge advantage initially to be able to contact patients directly and to have those conversations and those consultations. But I think we've come to realize that over the period of the pandemic, that you do need to intersperse with face-to-face contact, because often we were not getting the true picture. We were not getting an honest picture. We were not able to really see the therapeutic benefits of the engagement, and there were elements of potentially hidden harm as well, that and the environment that patients live in, that it's very difficult if we're not doing, for example, if we would normally have seen them in their own homes, to be able to witness them and observe them in those areas. We did, however, find that some patients really liked them. Some of the patients who are less socially sort of positive, they would find that actually it was a really good way, a very quick, sharp way of having a conversation and getting to the detail. So it does benefit some, but not all. I think we will certainly continue with it. That's not, we won't remove it. But I do think we have to recognise there's some safeguards that we need to put in place to make sure that mental health isn't deteriorating as a consequence.
Thank you very much. So obviously we're looking at utilizing telemental health in particular contexts, perhaps follow-up care, people who prefer it, patients who prefer it. So perhaps there has to be some thought in terms of where we want to position telemental health, and it is not really going to answer everything that there is. So I know we are already a bit beyond time, but let me also get Dr. Arun Kumar's thoughts on this, because telemental health in child and adolescent psychiatry practice. So there is an additional layer of, complications there. Your thoughts on that?
Yes, so, I have done telemedicine for the last 20 years. And my experience is you should know, what extent you can use it, as long as, if somebody is really psychotic, it is really hard to, ask them to follow through on a treatment. So it's knowing the boundary. So most of the, depression, anxiety, I have done even like autism evaluation over the tele for the children. So, you can definitely do new evaluations. There is no complication on that. As long as, especially with the children, you need to have corroborative information from parents and possible school. And even for some of the adults. And in fact, it's more easier when it comes to adult, when they come to clinic, they're often coming by themselves. So in a lot of time, I'll say, okay, can I talk to your family? Or is it okay to talk to your family? So, I had this lady I just saw, she gave me a clear history of depression. And then I could easily talk to the son, and who said that she does have manic episodes in between. If I would have seen just her, and without tele, it would not have been possible that her son coming to the clinic. So there are clear, there are some clear advantages, there are clear disadvantages. But the most important thing is, there are times when I say, this doesn't work in tele, then we have to see someone physically. So that is the boundary you need to figure out. Adi has been itching to talk about this for a while, so I'll hand it to Adi for a while. Go ahead, Adi.
Sorry. First of all, I just have to say, huge thanks to Anne, Murli, and Arun, yourself, and of course Isha and the Samvad team. This has been such an amazing webinar. I just wanted to add to sort of from Anne's comments, for the UK perspective, because that's where my clinical practice is. I think I couldn't agree more with all that's been said. I think telemedicine stroke virtual monitoring is here to stay. I think we should celebrate the fact that we now have the option. We certainly didn't in the NHS. I have to say our trust was a trailblazer. We have an amazing IT department, and within weeks we had this opportunity. It has not been the panacea that we were hoping for reasons that Arun and Anne and Murli have alluded to. You know, it doesn't work for everybody. And in children and adolescents, there is that extra layer. There are safeguarding concerns, seeing the child face to face. Who's listening in? We've done assessments, and actually you can tell the child's very distracted. And then you figure out that actually somebody's listening in. And so is their history reliable? Is it consistent? All those points. I do feel, however, I run a national second opinion service for children with really hard to manage mood disorders. And, you'd be surprised. We expect that children are the IT generation and they're almost born with Zoom and Teams embedded in their DNA. They actually hate being seen virtually. They want to see you face to face. There's something about the containment and the spaces they come to occupy, as Professor Sheshadri would always talk about. So I think there is something there, but I think hybrid is the way forward. Some initial assessments and the opportunity. And I think, dare I say it, not to, obviously working closely and being part of NEESAMA, I think for South Asia, for India, for Nepal, I think it opens up huge opportunities because of the distances and the lack of resources. So there is such a wonderful opportunity for us to work together to try and see this. But I will leave this with just one last comment. I think the question we should be asking is, who does virtual assessments work for? Isn't that important that we sort of know where it works, in what conditions it works, so that we can offer those people the assessments and not the others? So we're triaging and prioritizing. And I'll shut up.
Thank you very much for that, Dr. Aditya. So lots of insights, I think for all of us at both the individual and the systemic level. If I can just kind of summarize, some of the issues that were raised. So at the individual level, as individual professionals, perhaps we need to be looking at a skill upgradation, not just on the tele-mental health service arena, but also working face-to-face with infection prevention and control measures, right? So it's about upping your skills in both of these areas and not, one or the other. What was pointed out at the systemic and the organization level, it's about identifying what your system, what your organization is best at doing, and then, figuring out how to translate this into care and service delivery for the largest population that you can approach. So something that Anne said in the beginning, there was a conflict between the national interest, and Dr. Murraydharan touched upon this too. So the national interest is going to be COVID care, is going to be physical health care. Mental health care is not going to be priority. Mental health care funding may still take, as usual, many, many years, many, many decades to actually come up to optimum. So perhaps we may not be able to overhaul the system, but working with individual skills, working with system-based capacities and skills, that's the way forward as we plan our response to the already emerged mental health pandemic with the COVID-19 situation. A big thank you to all the panelists for joining us this evening with all of their expertise and all of their insights from administrative and clinical setups. Thank you to all the participants for staying through the session and also sharing in your questions that we all learned from. Have a good evening, and we will meet again on June 29th with the third session of this webinar series. Bye-bye.
Thank you.
Thank you very much.